A lot of us we have discussed about the male sexual dysfunction, diabetes, and sexual dysfunction. But here comes the counterpart. Because of a, at least in our society, because of a female partner, if that is not there and that is not satisfied, the sexual dysfunction happens in males also. So, for our because the diabetes is increasing and we find uh, very much prevalent presence of sexual dysfunction. But the topic given to me is that is underdiagnosed and overlooked. Means because we don't ask our patients don't volunteer this information. But in my gynae OPD, that may not happen with all of you in your diabetes OPD. Patients may not volunteer you the information of their sexual function, dysfunction, relationship. But in gynae OPD, we just ask them, how is your intimate health? Even if they are diabetic or non-diabetic. That has become the general question. If you have any issue, just talk to us. We are there to help you. So now coming to the topic per se, that is the sexual health. As we know, this is the complex of biopsychosocial process. Biologically, we have seen all these aspects. Social aspect is very important, which may create stress, and stress itself leads to sexual dysfunction. And psychological causes like maybe childhood trauma or psychiatric disorders may be there, which may lead to sexual dysfunction. And now coming to the patients with the diabetes. If we look at the female sexual dysfunction in diabetes, the overall prevalence is more than 50%, especially in type 2 diabetes. And it is less in type 1 diabetes. Maybe they are younger at their age, and when these studies are done, they are not have seen the complications of this. This is a sexual dysfunction is a long-term, long-standing diabetes complication or uncontrolled blood glucose levels. Means these two things, either diabetes is long-standing, is newly detected may or may not be getting sexual dysfunction, or they might present with sexual dysfunction and on investigation diagnosed with diabetes. Sometimes you find women coming with genital infections, severe vulvovaginal candidiasis, and we get a blood glucose test done, and we find she has uncontrolled hyperglycemia. So these things go hand in hand. So the common reasons are age factor, metabolic syndrome, and atherogenic dyslipidemia. These are strongly associated with the sexual dysfunction, and it is very common in postmenopausal women. That is more than 60% of women suffer from it. Quickly going through the definitions, that is the classification done in the DSM-5. Uh, the first one is the female sexual interest and arousal disorder. In this, the disorder of lubrication is very common, especially seen in diabetic women, female orgasmic disorder, and genitopelvic pain and penetration disorder. So in diabetes, desire arousal is very, very common. And next comes the diminished clitoral sensation, that they don't enjoy sexual activity and they don't achieve orgasm. That may lead to depression or the vaginal discomfort, dyspareunia, vaginal dryness may be associated with it. As the Dr. Ravindran has already told, the endothelial dysfunction is there. That is, it's not only for males, it's for females also. That may lead to lack of lubrication and dyspareunia. The risk factors are age, phase of life, type, duration of type is already discussed, complications, comorbidities, and concomitant medications. We usually ignore the concomitant medication while asking about the dysfunction. So we must look for it. Psychosomatic issues. Uh, Commonly seen in type 1 diabetes. Those who have body image issues, maybe obese, maybe very lean, or type 1 using insulin pump, they don't find the privacy or the partner may not like it. So that may lead to dysfunction. So interpersonal relationship issues and quality of life. Those who are already have poor quality of life, there are chances they will be having the sexual dysfunction also. And with the long-standing diabetes, the neurovascular complications are common, like neuropathy, peripheral arterial disease, coronary disease. All these lead to, in combination, lead to the reduced vaginal lubrication, decreased libido, and lack of orgasm. Means all the phases are affected. Coming to comorbid conditions, the metabolic one, the obesity and PCOS. These are really very common, as discussed in earlier lectures and in other halls also. The obesity and diabetes are very well discussed. So the body image issue comes here, and the commonly affected are the patients with the UTI and urinary incontinence. If you ask middle-aged women with diabetes Most of might be complaining about the urinary incontinence, maybe urge or maybe stress urinary incontinence. The other associated conditions and the psychogenic part. The label of diabetes may lead to depression or distress. Coping skills, quality of relationship, all these things are affected, and these affect their personal life also. Recurrence of occurrence and recurrence of vaginal infections leading to pruritus, vulva, lubrication, itching, tenderness. Even tenderness is very common complaint. They just get the small cuts at their vulva, even clitoral region, and they are unable to perform. Day-to-day activities affected. Concomitant medications, antihypertensive, lipid lowerings. Coming to the specifically the SGLT2 inhibitors, it is known to increase the renal glycosuria as well as the chances of the infection is there. Sometimes even if patient doesn't have the fungal infection, she gets the irritation with that. The urine glucose levels are +4 and she gets the vulval irritation. So we have to tell them about the local hygiene. They have to wipe the area after urination. Don't wash after each act of urination. From before backwards, they just wipe. That things help them. Or if possible, we should change the dosage or the type of medication to control her blood glucose. Our first aim should be best blood glucose control. So can we do this with all our patients? Should we go for universal screening or we should look for only vulnerable group? In our OPD, we just tell them this opening sentence helps them, they come up with their problems. Or if patient has unexplained poor glycemic control, depressive symptoms, or micro or macrovascular complications, in those cases, we should ask about their sexual dysfunction. So one should be proactive. But how can be proactive? Just sentence doesn't work. Just one question doesn't work. We may need in our waiting area with the FSFI 6, female sexual function index 6, or female sexual dysfunction index 6, or the if in these two screening tools, if we have kept in waiting area and we will find that patient is having dysfunction, we can go for further investigations and we can use the DEX depression inventory also. Don't forget history examination for the local lesions, phase of involvement, and we are asking whether she is affected with orgasmic dysfunction or just lubrication is affecting her, and relevant investigations as needed, we should go for it. We should sort out by identifying her phase and optimize her psychosocial factors, good glucose control, hygiene, and concomitant medication. It's not just one time job. We should supervise the therapy and outcome on the ongoing basis. With the management, as for males, it may be medication, but for females, it is the therapeutic patient education. That is the most important. And first of all, then comes the psychotherapy or couple counseling, non-pharmacological methods, and drug therapies. The therapeutic patient education has a theranostic approach, which should be age-specific, relevant to their marital status, sexual habits, and frequency. Just teach them anatomy and physiology of genitalia. We put a poster in our OPD and we just educate them. These are the part to be stimulated and how to do. Role of good glucose control and weight management. These are very important. If they have body image issue with obesity, just tell them if you control your weight and the waist, you will feel better. Psychosocial optimization should be done. And in Indian families, it's not a job of husband and wife. The whole family is involved. Even on the first night, they ask, Hua, you were able to do it. So the things start from the family matters. And sometimes the religious occasions are there and they tell them to refrain from sexual activity. So these things from, unless you go to a religious place, only then you can start your sexual activity. So that kind of restrictions are there in our society. So if needed, we should involve their family members also. Give them psychosexual therapy according to their need and according to their problem. Medical management, if we need, we can give them the medications. At start of the treatment, just it's not a placebo, but just to improve their mood, desire, we can give them sulbutamine, 200 milligram per day. Just 10 days is enough to let them feel better with this. We can give you himbin, sildenafil, low dose can be given, and flibanserin is also to improve the desire. Lubrication can be given with the local therapies in the form of gels and vaginal moisturizers. Oxytocin nasal spray is also available on Amazon also, and say it is imported, but people are using in India also and that gives them this is called as the hormone of love and care. So people like to use it. And if the patient is postmenopausal, as we have seen, more than 60% of postmenopausal women are affected with sexual dysfunction. We can give them the local estrogen therapy. The systemic menopausal hormonal therapy is not as effective as the local therapy for the diabetic woman. DHEA supplementation can be done, Tibolone, testosterone gel can be given, and ospemifene can be given to control the symptoms of postmenopausal. This is because of atrophy and the vaginal wall thinning, so that gets better. Lubrication is better with for orgasm. We can tell them the psychosexual therapy and coital alignment position. That in these cases, the chart helps them. We can guide them in a better position to, without any medication, they achieve orgasm. Other devices for this are vibrator or radio frequency, laser, vaginal ultrasound therapy can be used. And those who have urinary incontinence, the non-surgical procedure like HIFEM chair, Kegel exercises that can be suggested to them. And G-spot, O-shot, augmentation, labioclitoral fillers, those who have complex with their genitalia, this can be given. But all these therapies are to be done with the detailed counseling. And we must not forget in our patients, women, those who come with a vulvodynia. On examination, we find nothing on them. But still they complain, doctor, I get burning sensation over my genitalia. Just please examine. Those cases, they might be having provoked vulvodynia or generalized vulvodynia. And that is a marker of a sensory diabetic neuropathy. Local examination is must to rule out any other organic cause. Cotton swab test, tampon test can be done. And we can suggest them the local application of GABA mixed gel that contains the xylocaine and the pregabalin. And estrogen cream, oral medications can be given. And conservative cosmetic gynae therapies like PRP, laser, radio frequency, these have role in the vulvodynia. So in short, if patient presents with low libido and motivation, that means she has poorly controlled diabetes. But if she has low libido and high motivation, must look for her hormonal status like testosterone and prolactins. But those who have normal libido, they want to be sexually active but are less motivated. That means there is some psychosocial relationship issue with their partner. In that case, we should go for couple counseling. If they have both normal libido and motivation, then we should look for the complications of long-standing diabetes in the form of vascular or local factors. It might be she is having urinary incontinence and she doesn't want to be sexually active. Just to summarize, this is underdiagnosed, underreported, more common in diabetes. We should address it proactively in patient care because our patients don't volunteer, so it becomes our responsibility to ask them. It can be treated with therapeutic patient education, medication, and minimally invasive therapy. It's not everything needs surgery. Non-surgical options, cosmetic gynae options, rejuvenative vaginal medicine is upcoming branch that gives very good results. Optimizing sexual health improves the glycemic control and quality of life. Patients do it, and then you will see patient comes back and thanks that you have saved my married life. And I am happy. I am off my depression or off my depressing symptoms. Now my blood glucose levels are in better control.